Joining us today, we have Joshua Smith, MD. He is an assistant professor of psychiatry and behavioral sciences, the Division of Child and Adolescent Psychiatry at Vanderbilt University. He is one of the foremost and well-respected people in the area of autism and catatonia. So today I'm going to be interviewing him with Annabel Kuhn, and we will be going through all things catatonia in the child and adolescent sphere, how it uniquely shows up in kids, child and adolescents with autism, how it shows up in kids without autism. And he is someone who is doing this every day of his life. He's a true expert. I asked one of the most published people in this sphere who he recommended, and he recommended this person. So let's invite in our guest.
Thank you. I appreciate the invitation.
Yeah, I was enjoying listening to your YouTube the other day, and yeah, Annabelle, where do you want to jump in?
I think that I want to jump in by thinking about just like how interesting catatonia is as a diagnosis and how different it is from any other psychiatric diagnosis because so much of the diagnosis relies on a physical exam rather than like a mental status exam.
Right. Yeah, I mean, I think that it does make it particularly unique and I think raises our level of frequency of how often psychiatrists do physical exams. So it's a psychomotor syndrome, right, where you have very distinct physical examination findings that are consistent with the syndrome. And I think one of the reasons that it has this kind of um, level of interest sort of in the zeitgeist of psychiatric providers right now is that it's an exam you can do and you have a sick patient who's very ill, more likely than not, and then you give them an intervention, whether it's Ativan or electroconvulsive therapy or some other sort of multi-pronged pharmacologic approach, and they get better, which is great. But then they also have resolution of these physical exam findings, so you can actually track, your patient's improvement in a way that's unique. And what's interesting too is in our bigger paper that we published in Autism Research recently on the clinic, the 3 years of the data from the clinic, um, we noticed that we had statistically significant improvement in the Bush-Francis. So the standardized catatonia assessment measure that most everybody uses. And we also use something called the Canner, which is the Canner is a catatonia scale that's designed for neurodivergent folks. And it has a severity assessment measure, but it also has a standard physical exam. And we only found statistically significant improvement in the physical exam, which I thought was really interesting because that indicates to me that you can really track improvements with serial physical examinations in a way that is makes it unique, I think, in terms of treating different psychiatric conditions.
Maybe we should rewind a little bit and just for someone jumping in, what is catatonia? Like, what are the general symptoms, and then what are the specific symptoms we see in autistic patients?
Sure. So catatonia, was described in the late 1800s by Kalbaum initially, and it was described as this sort of stuporous tension insanity. And they also described fluctuating levels of psychomotor activity, right? I think that's like a hallmark of catatonia, where people have either hypoactive symptomatology or they have hyperactive symptomatology. And it is a syndrome in the sense that catatonia always occurs in the setting of something else. The analogy I give to parents and families is that catatonia is like fever, right? Like you have a fever, we don't really know why you have a fever, but you have a fever and we can treat it with ibuprofen, right? And that can happen in catatonia. We sometimes know why someone's catatonic, like in the case of NMDA receptor encephalitis, which is probably the most commonly associated medical condition with catatonia. And then we can treat NMDA receptor encephalitis, right? Steroids, rituximab, the full court press in terms of treatment options there, which improves the catatonia and the encephalitis. But in some cases, you don't, and you can have psychiatric symptoms that cause catatonia. So the most common of which are schizophrenia and bipolar disorder. In kids, psychosis seems to be the most common underlying psychiatric etiology for catatonia. And in adults, it is more likely to be mood disorder for bipolar disorder. And then you have these sort of underlying medical causes for the catatonia.
As you were talking, I was starting to think about delirium because this is another diagnosis that is
Yeah.
fluctuating and associated with another diagnosis. And so when you approach a case where you're witnessing fluctuating symptoms and potentially associated with another diagnosis, how do you really differentiate delirium from catatonia?
That's a great question. I mean, the DSM separates them out and says they can't occur. They can't be comorbid, but they certainly can. And it's really challenging. When we have folks who there's catatonia and comorbid delirium, we use our catatonia assessment measures, which I sort of already talked about, right? The Bush-Francis, the Cantor. Um, but then we use the Vedic, so it's the Vanderbilt. So this is for kiddos specifically. So it's a Vanderbilt assessment for delirium in infants and children, and we use both of those and try to basically assess for each. And again, back to the physical examination findings. Physical examination findings are like absolutely critical in delineating between delirium and catatonia. So if you have somebody who has waxy flexibility and they're stuporous, they're more likely to be catatonic if they're stuporous and inattentive without waxy flexibility, right? And the treatment plan is also kind of challenging, right? So when you have somebody who's delirious, hyperactive delirium, for example, the standard operating procedures to use antipsychotics. Well, antipsychotics worsen catatonia, right? And so you have to be really cautious around how do you delineate the. But when we first started talking, delirium is what I thought of too. Is that I think it is probably the most analogous condition in terms of the acutely altered mental status due to an underlying etiology.
So what are the most common physical exam findings that you're following and watching?
Yeah, I think so. Back to your initial question around the catatonia specific symptoms for kids and adults, right, and how those delineate. So when you can have hyperactive and you can have stuporous catatonia, and we haven't really, as a field, documented what are the most common symptoms. But the ones that are captured in the DSM-5 and the Bush-Francis, I think, are all something that should be part of the assessment. Um, so for the stuporous iteration, you have waxy flexibility, reduced oral intake, reduced fluid and food intake, reduced verbal communication. You either have again either stupor or excited levels of activity. Um, Aggression is also a potential symptom of catatonia. It's on the Bush-Francis. It's also on the Cantor. Increased impulsivity, poor eye contact, fixed gaze, new grimacing, um, mannerisms, so odd movements that don't seem to have a goal, and stereotypy is the repetitive movements. And when you start looking at pediatric cases, though, so for kids, the most common symptoms of catatonia are reduced verbal communication and reduced oral intake. And then when you
Would
look
that
at
be like the stuporous iteration of catatonia?
well, so yes, and a little bit there because catatonia is a life cycle illness, right? So it can happen at 6 to 96. But the younger you are, the more likely you are to have catatonia due to a neurodevelopmental disorder like autism. And if you have catatonia from a neurodevelopmental disorder, you're more likely to have hyperactive symptoms of
Do you
catatonia.
think that it's more likely to be associated with a neurodevelopmental disorder in kids because like psychosis, schizophrenia is less, and even depression is less common in kids than adults?
Maybe we don't really have the data to be able to demonstrate that. I think there's a lot of interest in why is there a connection between catatonia and autism? What I can tell you is that based on really large data sets that we've done our analysis on, is that kids, when they have catatonia, are more likely to have a neurodevelopmental disorder when they have the diagnosis earlier in life relative to, you're probably right. But there's also probably some sort of underlying biologic susceptibility to catatonia earlier in life if there is a comorbid neurodevelopmental disorder that we don't fully recognize. And so that, I think it's still to, be researched and explored in greater detail.
How common is this in autism patients like that you follow in your clinic?
It's more common than we thought it was initially. There's a great meta-analysis by Vicirzo Serrano. I think it was published in like 22 European Psychiatry, where they speculate that the prevalence of catatonia and autism is 10 to 20% or 10 to 12% of folks with autism will have catatonia across the course of their life at some point. And there are folks that argue against that because Vickers-Serrano's meta-analysis primarily included inpatient samples, and that's fine. But even if it's 5% or even if it's 3%, that's still a significant number of people who are having a very severe psychiatric syndrome that is A, hard to recognize, but is B, treatable if identified.
Take me through the time course. Like, let's say there was an autistic kid. What would be the first symptoms that normally come up with catatonia, and the second and the third and the fourth? Like, what is the time trajectory of this?
So when you have somebody who has autism, there's generally that initial early life regression, right? That's more sort of prototypical for an autism diagnosis. Like around 2 or 3, they have been normally developing, and then they fall off their developmental trajectory, and then try to get back as close to their developmental trajectory as they can, right? As they get older, if there is a second regression, that's when I start queuing into, is this catatonia for somebody who has autism? So that really any age past 4 or 5. And so what you're looking at is, limited engagement, a loss of personality, loss of ability to accomplish ADLs is another really big one. Some kiddos, like, they'll go from brushing their teeth to not being able to brush their teeth at all, and they need to, like, have folks prompt them or move the toothbrush for them. Reduced eating, reduced drinking, that's what really increases the mortality risk, especially. But then in neurodivergent folks and folks with autism, there's also this reported elevated rate of aggression without like an antecedent necessarily. It's just aggression that's happening in space without prompting, or this automatic self-injury that's not. It's not a way of communicating with someone, right? So it's self-injury that doesn't have necessarily a purpose. And so those symptoms are what starts to cue me into, this may be catatonia in an autistic individual who's early in life. And we've identified folks as early as 4, where it's like they've had their initial regression, they're getting back, and then they have a really big regression and have those sort of symptom clusters that we followed in clinic here.
For kids who are past beyond the age of 4 and having these behavioral regression symptoms, that would really perhaps could indicate to a clinician that this might be catatonia more so than if it were to happen um, like before age 4. But
Yeah.
I just wonder, are there other besides the aggression and irritability and loss of skills after age 4? How else can catatonia be differentiated from behavioral regression or skill loss in autism?
Yeah, again, it comes back to the physical examination findings too. You sort of hit the nail on the head at like 2 minutes in. So, but like it is tremendously helpful to be able to conduct a standardized physical exam like the Bush Francis or the Canner, and be able to, because the differential is, and you sort of are hitting on this, right? The differential is broad. If you have someone who comes in with skill loss, or if you have someone who comes in with irritability, that can be depression, right? That could be other mood symptoms. It could be psychosis, so on and so forth. But if you have those symptoms in the presence of physical examination findings, that's certainly cueing you in.
So I imagine that it would be really hard for a telehealth provider to examine someone with catatonia. Is that fair to say?
Actually, we just published a paper a year ago where we looked at the sensitivity of assessing somebody with catatonia over telemed. And if you can get the family to engage in the Bush Francis, the sensitivity remains pretty high. It's like 98%.
Wow.
So, and I do a lot of telemedicine visits, and it asks a lot of the family for sure. But you can send them videos. I know you guys have had Dr. Oldham on here, and like you can send them Dr. Oldham's Bush Francis videos and have them review, and you can actually have the family do it in real time. So, telemedicine is actually not an unreasonable way to assess folks in the community.
With the nonverbalness in some autistic patients, how do you determine some of the mutism?
It's basically losing what communication ability they have, right? Which is not captured on the Bush Francis or the Canner. So a classic example is somebody who uses the AAC device, like they're, using artificial communication and then they stop, right? Or they're nonverbal and they sign and then they stop signing. And generally what I've seen in clinic is that's also accompanied by vergibration, so the nonsensical noise production. So even if someone's nonverbal, they go from, we'll say someone's limited verbal. Say they have 30 words, right? So they'll have 30 words, that drops off, and then they try to communicate with nonverbal gestures, and then that drops off. And then they usually engage in screaming or some other sort of distress sounding vocalizations that we would call vergibration in the setting of catatonia.
Okay, you said something else there that was interesting. You said like the type of violence is different between catatonia and maybe just autism with violence. What is
Hmm.
the difference between the two?
Yeah, this is a particularly a big area of interest for me because I take care of mostly folks with profound autism, and I want folks to consider catatonia on the differential when there's worsening aggression, because it's a treatable cause of aggression, and there's so many causes of aggression that aren't treatable, right? And it's just the severity and nature of it is really devastating to families, and so if you can intervene and treat those things, it can make a big difference. Um, so the when you have somebody with profound autism, it's not uncommon that they're aggressive, right? Like that's not unusual. Um, but the question is why, and then also trying to assess for the severity and frequency. So if a kiddo is aggressive, but they're aggressive because their parents are taking them to a place they want to go, that's different, right? That's the kid communicating, I don't want to go to this place, but they don't have a good way of communicating, particularly if they're minimal verbal or nonverbal, right? Or self-injury is the same way. So if a kid doesn't want to go to bed and they engage in self-injury, that's communicating to the parent, I don't want to go to bed. The levels of aggression and self-injury that you see in catatonia, they're not driven by something like that. They're not driven by like a cause and effect. They're just happening all the time and they're sort of indiscriminate. Like we've had families who say, we can't even go to the grocery store because if our kid passes somebody else, they'll attack them, right? Or they're just engaging in self-injury nearly from the moment they wake up to the moment they fall asleep, and there doesn't seem to be a rhyme or reason. So that's a differentiating factor there, right? It's both intent, cause and effect, but also the intensity, severity, and frequency of when it's happening.
This is really good. What are some more pearls about the diagnosis that you would want clinicians to know about that they don't know about?
Uh, well, I think that again, considering catatonia on the differential, I think is really key because what happens sometimes too is you can also get we haven't really talked about negativism or oppositionality in catatonia, right? Which is a cardinal feature of catatonia, where folks will either can't do what's asked of them or they do the exact opposite. It's called active negativism. It's like the most severe iteration of that, right? But it can be misconstrued as oppositionality from a kid who just presents the emergency department. So if you have a kid who previously was following instructions for their family just fine, and then the next day or a week or a month later or something like that, they can't do any of those things, or they don't seem capable of following directions from their family. You present to the health system, and folks are like, well, they're just being oppositional. They don't want to be in the ER, so on and so forth. It's like, well, we need more information, right? I mean, that may very well may be the case, but if we can't do anything that we previously were capable of doing, then that starts cueing me into is this negativism from catatonia rather than just sort of baseline oppositionality. And it's easy to sort of falsely attribute a kid not wanting to follow instructions to just oppositionality or not wanting to be in the hospital or not wanting to do what the adult's telling them to do, right? And so I think making sure that that's on the differential is key as well when you see again a big departure in terms of personality and in terms of engagement or aggression or negativism. I think the big important pearls are, it is a life-threatening illness. Oral intake can be reduced, and that can be really scary. And a lot of these kids present to hospitals when they're not eating or when they've had, their symptoms first occur. And then,
Real quick, with the negativism, it seems like this is so vital because, you know, all of a sudden the child is doing the exact opposite of what you're asking.
right, yes,
And it's
yes,
like everything in you as a clinician is like, oh, are they just all of a sudden being rebellious?
right,
You know?
right.
And it's such a good differential. Just want to say that. And then the oral intake, not drinking, not eating. Um, when does that happen in the course? Is that like the first week these things start happening? Like, like when do you usually see that happening?
We don't really have good data on that necessarily, but and it depends on the kid. So we have some kids who've come in and they're floridly catatonic 3 days after the catatonic symptoms started, right?
Mm.
And when I say floridly catatonic, I mean requiring IV hydration, NG tube feeds. It's very quick. And in my experience, again, this is not as data driven as I like to be, but in my experience, that's generally in the case of encephalitis or first episode psychosis, where catatonia is, accompanying the acute symptomatology. Um, what I'll say is that for more of our chronic catatonia patients who in our clinic generally have autism, the ones who have residual catatonia symptoms, the oral intake the issue can come and go, where it's like, hey, they won't eat for 3 to 4 days, then they'll eat for a day, then they'll go to 3 to 4 days. It's not as clear a delineating line as some of the other kids who have presented to the acute care setting. So it's difficult to know, and I think it also I think highlights the need to be really clear and collaborative with parents around timeline of symptoms. Because if a kid goes without eating for a couple days, your differential is more broad than if they go without eating for a couple days, but they also have lost their personality and are not doing ADLs and are posturing, right? So just making sure that you're assessing for all sort of factors of the particular symptoms.
For clinicians who suspect catatonia in the outpatient setting, and let's say there's no poor like PO intake is intact, would you still recommend the family bring this kid to the ED?
Hmm. That is a great question, and my answer is it depends. So, it depends on how severe the oral intake issue may be, and it depends on how quickly you need them to get a medical workup, right? So,
Okay.
it's really important when kids across the spectrum of neurodivergence or age present with catatonia to do a full medical workup, including brain MRI or LP if that's clinically indicated, right? Definitely baseline labs, definitely physical exam, definitely having pediatrics weigh in, and so the questions in my mind, if a kid presents to my office and has catatonic symptoms and they have not been assessed at all, like let's just say they walked in my office, see them here, they've never seen a doctor before and they're catatonic. Um, I would start Ativan for sure. And in the outpatient setting, so in the inpatient setting, you can do the Ativan challenge, right? Where you can go and give them repeat doses of Ativan until they fall asleep and then reassess them. Outpatient's more complicated. So I generally start low and go slow and do 3 doses of Ativan and like 3 doses per day, start at a 1/4 milligram, go up every couple of days, and then coordinate with the family, generally through the My Health system and on Epic around if they're sedated at higher doses. So that's what I'll do in terms of pharmacology. If I see them here and they've never had any medical workup and they've never seen a pediatrician, they haven't been eating for a week, I will absolutely send them to the hospital for sure, right? It just depends on A, how much medical workup do you need based on when they're coming in, and then B, how acutely concerning are their symptoms right now in terms of their medical stability.
Is it the encephalitis that you want to rule out by sending them in? Is that the main thing, or is there some
Yeah.
just
And
the mixture of things?
the answer is yes, and like I mean, encephalitis is certainly the number one thing I want to rule out because time is brain, right? Particularly in encephalitis cases. And if a kiddo has encephalitis, we need to go ahead and be doing steroids, monoclonal antibodies, whatever it is that we need to do. So yes, encephalitis is the number one thing. But again, you can have catatonia from a myriad of different medical conditions, and it's really broad. And so you oftentimes need to do a lot of labs just sort of as a general assessment to make sure there's no sort of metabolic derangement or other medical etiologies that are causing the catatonia.
Okay. And so you said something you give the Ativan every hour until they fall asleep. Tell me more about that.
Yeah, so that would be in the inpatient setting, not in the outpatient. Just to clarify,
Yeah, yeah, yeah.
I don't want anybody slinging that much
But,
out of the
Oh, but
walk
community.
that's still interesting. I mean, that's not how
walk me
I've,
through that.
yeah.
Walk me through that. What do you guys do?
So we actually published a paper on this. It's called Roadmap. It's the Vanderbilt Roadmap for Catatonia. It's in the JCLP. But basically, what we do is we give an Ativan dose, like a Ativan challenge dose, with a max of 2 milligrams of Ativan for the single dose. And then we go back and reassess to see how their symptoms have improved. And we repeat the Bush Francis every hour when we go and evaluate them. So we give them 2 milligrams, and then we'll come back and give repeat doses based on their weight until they have. Are you guys familiar with the Richmond Agitation Sedation Scale? It's we use it in so basically it's a Likert scale of agitation that folks use in the hospital. So 0 is like not agitated at all, and then there's +1, +2, +3, +4 as increasing levels of agitation, and then -1, -2, I think it goes to -5, but levels of sedation. So we basically repeat the doses of Ativan until they have resolution of their catatonic symptoms or they have a RASS of -1, which means lightly drowsy. So that's the assessment that we use. So we try to be pretty proactive, and that's an idealized situation, right? Like in reality, you're doing that, and you're also being called to behavioral codes or doing a new consult or something.
Yeah.
Like you can't just be standing at the bedside the whole time. But that would be the idealized version of that.
Okay, so in this
Oh,
idealized version, what kind of doses are we getting to in the first day? Like cumulative doses.
It depends on the kid. We published a paper on the number of the 150 kids that were admitted between Mass General and Vanderbilt, and the mean dose of Ativan for those kids was 6 mg for stabilization of their catatonic
per day.
symptoms per day, per day, right? Um, and so I think in the hospital setting, in the acute care setting, thinking about it in that dose range is reasonable. But what I will say is that our clinic paper that focused primarily on folks with autism and catatonia, the mean dose of Lorazepam was much, much higher. It was 20 mg. And so there's a pretty wide discrepancy of what people need in terms of stabilizing their catatonic symptoms. But we try to follow the old adage of catatonia care where you continue to dose until sedation and then reassess.
What percentage of people do not respond purely or as much as you would want to Ativan, and you have to move to other types of treatment?
It would be a guess, but I would say probably I think 80% of people respond to Ativan, I would suspect. That's just a guess. But the what I would say though is that the majority of patients that we have followed longitudinally have needed more treatment than just Ativan, particularly our neurodivergent folks. So whether that's an NMDA receptor antagonist like memantine or amantadine or Depakote or clozapine or ECT, the majority of patients we've followed longitudinally in clinic have needed additional either pharmacologic or neuromodulatory interventions.
So for kids who've had a paradoxical reaction in the past to Ativan and now they're presenting with catatonia, how would you approach that situation?
That's a tough one. It again depends on the severity of their symptoms. So if they're coming in and they've had paradoxical reactions, and we have a couple of cases like this, if they have intractable aggression or they're not eating or drinking, I'll usually go ahead and start pursuing ECT at that time. And then I would also simultaneously do memantine, an NMDA receptor antagonist, or Depakote at that time. So that's usually my approach.
Got it. And so, yeah, I would love to hear your thoughts of like if a kid isn't clearly like having a, let's say, for example, they're on 20 milligrams a day of Ativan. There's no clearly robust response to Ativan. What would you do from that point? Like, what would be your next step?
Have we pursued ECT yet?
Not yet.
Okay, I would have done ECT a little earlier. I think that I wouldn't let them get up to 20 mg. I would go ahead and start doing ECT if they're not
Oh, wow.
responding at all. And that's tricky. I'm also the medical director for neuromodulation here, and the the laws around electroconvulsive therapy are really variable from state to state. In Tennessee, if a kid needs ECT, you have to have two consults completed by one by a CAP psychiatrist, and then another one by the ECT doc. And then that's if they're 14 to 17. And if they're under 14, you have to do that. But then you also have to do a multidisciplinary meeting of 5 people and go to court and get judicial approval. And so that process can take a really long time. Um, so anyway, if someone came in and they were having that level of symptomatology at that dose of Ativan, I would do, I would continue the benzo. I'd start at an NMDA receptor antagonist. I would start pursuing ECT, and then there's an algorithm for it. There's a great paper by Beach in 2017 where he does an adult algorithm that I follow roughly, where it's benzos, ECT, NMDA receptor antagonist, valproic acid, and then either aripiprazole or clozapine as that sort of last line, because those are really the only two antipsychotics that have shown to be, potentially efficacious in catatonia.
Joshua, this is first of all really, really helpful, I think. Just the general like putting this on people's roadmap. As I'm talking to you, I'm on X a lot, and there's a lot of anti-psychiatry people, and every time they say something anti-psychiatry, I just want to say, do you know what catatonia is? Do you even know what catatonia is?
Sure.
And then that question makes me want to ask myself, how long until neurology steals this diagnosis from us?
I think they're good.
Yeah.
Okay, good.
It,
I mean, watch turf, but no, I think that they're okay. The fact that ECT is one of the hallmark, if not the hallmark treatment for catatonia
And
means
it's the only FDA approved treatment for
right.
catatonia, even. Yeah,
Right. It means that catatonia, I think, is in psychiatry to stay.
cool.
My dear neurology friends, I don't think have any interest in cross training in ECT with us. Though if they do, I'm happy to accommodate them. But that has not been the case thus far.
okay,
Excellent.
so if they did respond to Ativan and they're out of catatonia, they're doing so much better.
Mm.
Um, my perspective is you treat the underlying issue, if
Yes.
there is one. And then secondarily, my mentor taught me go down very slowly on the Ativan, like
Yes.
half a milligram once a month, with which no one knows that. So tell me what your perspective is and how you roll.
I do the same thing. I am incredibly cautious around tapering benzodiazepines. And I go, it is, I tell the families I see in clinic, it will be so painfully slow, it will drive you nuts. But I think it's critical because the symptoms coming back is not what we want, right? Like we're in the hospital or we're, severely debilitated secondary to the symptoms, so we have to be cautious. There's not very much data on benzodiazepine tapering in the literature. We did include our tapering data in our autism and catatonia paper, and what we found was that we tried to taper benzodiazepines for 12 of our 45 patients, and we were only successful in absolutely stopping benzodiazepines for 5 of the 45 patients that we had in that sample. And so what that tells me is I think we conceptualize catatonia as an acute condition, and understandably so, right? People come to the hospital, they're acutely ill. We do a benzodiazepine challenge, we do ECT, but there's just not very much written about what happens when you go to the clinic. I think tapering is challenging, and I suspect, 'cause I don't have this data because I primarily focus on folks with autism and catatonia, but I suspect there's probably greater success in tapering to discontinuation for neurotypical folks with catatonia relative to neurodivergent folks. And so, but that question has to be answered. That's just my hypothesis.
Yeah, that makes sense. And I'm surprised it was 5 out of 45 were able
Yes.
to totally taper off of it. Yeah, like there was one patient who I saw who is on a very high dose of Ativan and is now outpatient getting ECT, still on a very high dose of Ativan though. And anytime it's decreased by the even tiniest amount, like quarter of a milligram, things get worse. And he either has to go back to the hospital or dose has to increase. And it's really unfortunate.
Yeah.
Maybe, but I mean, if the treatment helps, that's great. But I think for parents who are, yeah, they're really concerned about having kids on this high of a dose of benzodiazepines. How do you coach parents or guide parents through the rationale of why
Mhm.
we're prescribing such a large dose?
Yeah, and I'll also add that we run into that with ECT frequency too. W-
Yeah.
where it's like we try to taper kids to weekly or something like that, and they just fall off. Um, I coach families on that by saying, listen, we do not understand or fully appreciate the ramifications of taking Ativan for years and years and years. And there's also not longitudinal data on this. That's why we have this research clinic where I follow up with these folks. But my assumption is that it's better to be on Ativan and not be catatonic than to be off of Ativan and be floridly catatonic for your long-term life trajectory, right? There
Hmm.
is, concern that taking benzodiazepines for years increases your risk for dementia. Absolutely. But there's also, you have to be able to live your life and function and eat and stay alive. And so when you are looking at it and comparing those two options, it's hard, and I really empathize with my families a lot around like how do we make this decision together and collaboratively around what are you comfortable with your kid taking for how long and how low can we get them without any residual symptoms returning? It's a difficult conversation to have, but it's absolutely critical.
What about a similar type of conversation? How do you approach the option of ECT with families,
Mhm.
especially those families who have seen ECT in movies and are really hesitant, didn't even know that psychiatry still does ECT
Mhm.
routinely. Yeah.
It's a delicate conversation around. I frankly own the fact that ECT started off not with great marketing, right? Like we used to not use generalized anesthetic. We didn't use paralytics. We didn't put people under sedation and paralyze their muscles so they don't have a big herky-jerky tonic-clonic seizure like you've seen in the community. I also think One Flew Over the Cuckoo's Nest did a huge disservice to the ECT access, really, because it was a movie everybody saw, and the way it was portrayed, I think, has set ECT access back. But I'll tell families, I'll say ECT's come a long way. Yes, the procedure is largely the same, but we have made changes to the procedure, including modified ECT where people are under sedation and paralyzed. And I also I'll get really nitty gritty with them. And I'll tell them like as much detail as you want, I'll give you, where I'll talk about we moved from sine wave pulses to block wave pulses, and we can do brief pulse or ultra brief pulse. That there's modifications that we've made that have improved the clinical outcomes and also the side effect profile for ECT. But I walk them through every step of the situation and what they can expect when they come in and get treatment. But so many of my families, when they eventually find me or see me, their kids have been sick for so long, they really just are saying, please, anything we can do to get my kid even, 30, 40, 50% closer to where they were, as close to their baseline as we can possibly be. And so I think just again being able to sit in that with them and talk about like this is a really difficult thing for us to walk through together. But if we look at the data and we look at the literature, I mean, ECT has been used for children since 1940, and so there's almost 100 years of data that supports its safe and efficacious use. That doesn't mean that it's not stigmatized, and that doesn't mean there's not side effects, but just having a very candid conversation about that sort of in all fronts.
I think another challenge that adds to ECT and catatonia and kids with autism, so often, not so often, but frequently, a seizure disorder can occur in association with an autism diagnosis. And so I would imagine that for a kid with a history of seizures, even if it's remote, it might make people hesitate to consider ECT.
It does, but it shouldn't.
Okay.
So you can actually use ECT to treat non-convulsive status epilepticus. There's protocols at various hospitals, not here, unfortunately, but there's one published, I think, by the University of Maryland, where ECT actually can improve seizure outcomes for people that have comorbid epilepsy. Now, I say all that with this caveat. You have to be absolutely really careful when you do it because folks with epilepsy are at an elevated risk for having prolonged seizures from ECT, and kids are at an elevated risk for having prolonged seizures from ECT. So if we're doing like a hypothetical scenario, if you have a kiddo who comes in, they have profound autism, catatonia, and epilepsy, and this is not an uncommon sort of triad of diagnoses, then what we do is we start as low as we possibly can on the energy from the ECT machine, and then we slowly up titrate it over time to see what that person's going to be able to tolerate. That's both efficacious but doesn't result in prolonged seizures. The data is pretty clear that kids have longer seizures relative to adults at lower energies, and so we have to be cautious about that. And then again, in the setting of the comorbid epilepsy or seizure diagnosis, it's a critical consideration.
If Ativan isn't working, would you try a different benzodiazepine like clonazepam? And has that seemed to be more helpful in certain situations?
I definitely do. And I used to use diazepam with relative frequency, but I don't do that as much. I usually either use lorazepam or clonazepam. That's my own comfort level. That's not as data driven. We have published papers on the use of clonazepam, and actually I started using clonazepam. It was a little bit of a happy accident during the lorazepam national lorazepam shortage. We were just out, like we didn't have any. And I started thinking about though, and so many of our families were saying, "Hey, my kiddo is having breakthrough symptoms the next time their Ativan dose is due." And I was like, "Well, I don't have any Ativan, but I can use Klonopin, and we can try to dose it 3 times a day." And so oftentimes I always start with Ativan because I mean Ativan's the gold standard for sure, right? Like no one's contesting that. But if I have a family who says, "Hey, this is working great, but around noon when I'm supposed to give this next Ativan dose, we're having a ton of mannerisms and stereotypies and self-injury," I'll switch to clonazepam in that setting. And I have used diazepam successfully, but I think its half-life is so long. I think it's more likely to cause sedation and stupor as a consequence of the diazepam, not the catatonia, right? So
Mhm.
yes, generally I will consider longer-acting benzodiazepines if folks are having breakthrough symptoms for sure.
Have you personally, in your clinical experience, seen memantine give any significant benefit?
That's a great question. So of the 45 kids that we treated in that study, we had one kid who didn't need any benzos, and I treated him with memantine, and it was like gangbusters. That's not, I think, the majority of cases. And most of the time when I'm reaching for memantine, I'm using it in conjunction with the benzo. So I don't know if I can really give a lot of credence to just using memantine as monotherapy, because oftentimes it's I'm using both of them at the same time.
Um, okay, so in kids without autism, what type of catatonic symptoms do might be there that might not be in someone with autism?
There's not a specific symptom that I would expect to see in a neurotypical kid that I would not expect to see in a neurodivergent kid. The symptoms are crossover significantly, but there are symptoms in kids that I would not expect to see in adults, and those are specific in the pediatric catatonia rating scale. So that includes acrocyanosis, cold extremities. That's in the pediatric catatonia rating scale, but not in the Bush-Francis. New onset urinary incontinence is also in the pediatric catatonia scale, but not in the Bush-Francis. Schizophasia is similar as well, scrambled speech, and then automatic compulsive movements. So I think it's actually more of a delineation between adult catatonia and pediatric catatonia relative to like neurotypical or neurodivergent catatonia. I think you can expect pediatric specific symptoms rather than like in adult specific symptoms rather than neurodivergent or neurotypical specific symptoms.
What about when you first start treatment, like with the Ativan challenge? I think that I read somewhere and I couldn't find this article. I feel like if it exists, I may have read it 5 years ago, but I seem to have read somewhere that if you give an Ativan challenge, in some cases, the Bush-Francis score may go up, but it still can be confirmatory of a catatonia diagnosis. Does that sound familiar?
Sure. Yeah, I think that I don't know if I've read that paper, but that is my experience where particularly if a kid is stuporous or like
Mm.
not engaged, and then
Yeah.
you treat them and they have hyperactive symptoms, you could definitely have an elevated Bush-Francis, right? Like if a kid is stuporous and has waxy flexibility and you treat them and then they start or they're aggressive and impulsive, your score could go up, but in theory that's a positive finding, right? So, the Bush-Francis is I mean, it's revolutionized the way that we take care of catatonic patients. But at the same time, it's not a perfect assessment for looking for clinical improvement. And in fact, in our larger one that study I referenced, the inpatient study with the 150 kids, we found statistically significant improvement in the Bush-Francis for kids that were admitted and then discharged. But we didn't find that the Bush-Francis correlated with any other symptom severity metrics. So like length of hospitalization, dose of benzodiazepines, the score of the Bush-Francis did not correlate with those sort of secondary clinical outcomes, right? Like when we first looked at it, I thought a Bush-Francis of 30 would be indicative of a longer length of hospitalization or a higher dose of benzos, but that wasn't the case. And so I think what that means is that we just need to consider the Bush-Francis a tool for those assessments, but then also be aware that a score change on the Bush-Francis is just another, you know, data point for you in your sort of overall clinical assessment.
I would like to go through and do rapid fire. Like I'll say the Bush Francis like the word that's associated with like the scoring, and you tell me how it presents in someone who's a child and adolescent. Okay.
A child and adolescent or a kiddo with autism.
You can differentiate it if you want. Okay.
Okay, okay.
Okay. Excitement,
So frenzied motor activity, not being able to stop moving, bouncing around the room, despite having high doses of sedating medicines.
immobility, stupor,
So immobility and stupor, I think, is well described. So essentially, like limited movement, limited engagement, not interacting with the interviewer.
mutism,
Neurotypical kid who is usually verbal, limited at verbal output or no verbal output. Neurodivergent kiddo who uses sign language or AAC device, stopping using communication devices.
staring,
Staring is tougher. So it's well described, right? Where it's like poor eye contact and limited eye contact. The worst iteration of that is fixed gaze or not shifting attention across the room. But what I'll say is that you can also see that in discrete moments or periods where it's like they're having a few seconds of staring. It doesn't have to be an hour long experience.
posturing, Catalepsy.
Holding abnormal, odd movements for extended periods of time. But again, similar to the staring, you can have that posturing, but it doesn't have to last an incredibly long amount of time. So particularly in our neurodivergent folks, what we've seen is they'll have posturing that lasts seconds, but they'll be in the middle of an aggressive episode or hyperactivity, and they'll do this, and then they're back at it, right? So I think we have this sort of classic hypoactive version of catatonia in our brains a little bit, where it's like they have to be doing this for an hour, but that's not necessarily the case.
Grimacing.
Grimacing is tough. It's involuntary facial expression where you're doing like gestures like this, and then you can have prolonged cramping where folks will hold that position for 10, 20 minutes longer for an hour.
Echopraxia, echolalia.
Echolalia and echopraxia are the mimicking of either movements or words, right? So you say something back to them and they'll say it to you, say it to you, say it to you, say it to you. So that's echolalia. Echopraxia is the mimicking of movements they're watching the examiner do. Right, exactly. Yeah. So David's doing he's engaging in echopraxia now. What I will say is that you can see echolalia and echopraxia at baseline for autism, right? So it's really critical to talk to the family about, was your kiddo having echolalia and echopraxia before they had the mental status change? And if they are, is this more frequent than what they had been doing? Again, trying to establish a baseline and determine if it's a departure from it.
Stereopy.
So, stereopy. So, again, the flapping. So, this is an interesting distinction. So, a lot of our trainees have a difficult time with delineating between stereotypies or mannerisms. And the way that I conceptualize it is stereotypies are repeated movements, right? So like hand flapping where there's like a frequency to the movement, that's a stereotypy. And then the canner, not the Bush Francis, but the canner measures stereotypies in terms of self-injury. So if it's like head slapping, that would be a stereotypy resulting in self-injury.
Does a stereotypy have to be different from a stim that's present at baseline?
No.
Okay.
Mannerisms.
So mannerisms are odd movements that seem to have no necessary purpose. The classic example is someone randomly saluting, right? But in the canner, they judge that based on self-injury. So if self-injury is a part of that, it's a higher score, and that can include things like swallowing coins, gouging, like trying to stick a finger in the eye, so on and so forth.
How do you describe Mitgehen?
Mikahin is it's the passive engagement with the examiner, right? So the classic example is you lightly tap on someone's arm and they drift all the way up, right? And then they hold it there. So it's a passive, it's passively following a suggestion, right? So that's the sort of classic distinction of it, or the idea conceptualization.
Would it be positive even if like the hand goes up a little bit?
Yeah,
Not necessarily doing the whole angle poised
right,
lamp. Okay.
right.
What about Gegenhalten?
Gegenhalten is equal and opposite resistance when you're doing an exam. So the example I give is I always grab someone's arm and I measure their tone, right? Because you can have increased or decreased muscle tone in the setting of catatonia. The Bush Francis only measures increased. The Canner measures both plasticity and rigidity. So I measure for that. And then I'll pull against their arm. And if I'm pulling and they're giving me equal and opposite resistance when I am trying to extend their arm, that is that's a positive sign for Gegenhalten.
Got it. What about automatic obedience?
It's a tougher assessment. The canner actually combines ambitinency and automatic obedience, but in theory, automatic obedience is following instructions after being asked not to do so. So the classic one is like, I have a needle in my pocket. If you stick out your tongue, I'm going to stab your tongue. Don't stick out your tongue. And then they stick out their tongue. For kids and for folks that are neurodivergent, I just say, I'm going to ask you to shake my hand. Don't shake my hand. And then I'll extend my hand and see if they shake it. And that way there's less sort of, that's my own practice, but that way there's less questions being asked of them or less commands they have to follow.
What about verbigeration?
For gibberation is basically nonsensical noise production. So if you watch the YouTube video, the boy on the YouTube, he screams at the floor, and that's what I would call vergibration. He had been verbal, so he went from verbal to nonverbal to screaming. So that sort of, and again, nonsensical noise production is how I would categorize vergibration.
Rigidity? Did we do that one?
hmm Yeah, so increased or decreased muscle tone. Increased on the Bush Francis, increased or decreased on the Canner.
Negativism?
So like, we talked a lot about oppositionality. That falls into that category of negativism. So is it oppositionality because a kid is being oppositional, or is it negativism because they can't follow your instructions? That's the delineating line there.
Waxy flexibility.
So that one is like if you put their arms in a position and they hold it like a candle, right? So that's more of the classic version of catatonia. Like if you Google catatonia, you'll see someone who's waxy has waxy flexibility. And essentially, like you can put them in this position and they'll hold it and they'll kind of slowly drift down over time.
How's that different from passive obedience?
I mean, you mean from the Mikahin?
Yeah,
So the Mikahin, you're actively not active, you're doing something, right? So you're tapping their arm and they're following your suggestion. That's Mikahin. Waxy flexibility, you put their arms there and they hold it and then they slowly drift down over time. You could make the argument that they're two sides of the same coin, essentially, right? Like there's this like passivity of allowing you to put their limbs in different positions, but they're just two different ways of assessing that.
I think about posturing and catalepsy, and that feels pretty similar as well.
Yeah, it's that you're essentially assessing similar symptoms in different ways.
Got it.
Withdrawal.
So withdrawal is primarily categorized as is food, liquid or food intake on the Bush Francis.
Impulsivity.
So again, impulsivity is pretty, I think, pretty descriptive. But what I would say is that in catatonia, that can become so severe that it's life-threatening, right? Where people are jumping off of, a second-story balcony, or they're swallowing coins, or running into the street spontaneously. So it can have a very severe overall presentation.
Mm.
Did we do ambi-tendency?
No, but ambitendency is fascinating. So ambitendency is essentially getting stuck in a movement or stuck in an action. So if you ask someone to shake their hand and they reach out and they get stuck from actually doing it, or they're reaching for a cup and they can't completely cannot completely finish picking up the cup. And another example of that is actually when people cross different floors. So if you have tile floor to carpet floor and they can't walk across that, or they can't walk through a door threshold, you can see that as well.
Hmm. How about grasp reflex?
Grasp reflex is just folks they're grabbing everything that's next to them. It's not the neonatal sign where you rub the inside of the hand. It's essentially like grabbing everything that's next to them.
Perseveration.
This one is very, very tricky to delineate in autism because the core feature of autism, criterion B, is restricted interest repetitive behaviors, right? So is this restricted interest repetitive behaviors or is this perseveration? The way that so perseveration is like an obsession with what's happening or a movement, a physical movement that won't stop. So someone's like moving their hand like this and then they can't stop moving their hand, right? Then how do you delineate it if it's a cognitive perseveration? So we've had folks in clinic who, I don't, they love cartoons, right? So they want to watch cartoons all the time. And that's when they're autistic without having catatonia. Then they develop catatonia and they only want to watch the same 3 seconds of the same show forever. So that's the distinction, right? It's an increased level of severity and frequency rather than the like restricted interest repetitive behavior.
And combativeness. We talked about this, but go ahead.
Yeah, I mean, again, it's the frequency, severity, and nature of it. Can you go outside without your, patient attacking somebody, right? And it is indiscriminate and without having a reason for the aggression occurring, or, it's not that they're scared or they're not trying to, or they're trying to communicate. It is a indiscriminate sort of aggression.
Autonomic
And
abnormality.
so this is a really interesting one that we've discussed a lot institutionally because we wrote that paper and we developed a roadmap for assessing these kids, and it's how do you define autonomic instability in a kid who's catatonic. And so essentially what I would say, if their heart rate is elevated, their blood pressure is elevated, or opposite, if it's too low, then those can be considered autonomic instabilities, but those numbers are not hard and fast. I think it's again tracking over time what those look like.
Okay. This was great. This is really good.
Yeah, thanks for the
This was
invitation. I
so
really
fun,
appreciate it.
and I learned so much.
Yeah.
Thanks. Yeah, well, I really appreciate you
Absolutely.
guys being willing to have me on. I had a great
Thank
time.
you.
This was probably the most fun I've had today. So.
Oh,
Oh,
I'm so
great.
glad. Me
Great.
too.
Well, okay, so like we're just for the audience, like let's say someone was listening to this and they're like, how do I get help in my state where I'm living? Like,
Mm.
is that even available? What would you say?
So there's the CatatoniaFoundation.org. They're a nonprofit their whole mission is to try to plug people into resources. So I would start there. Folks can email me if they really need to. But I think just trying to touch base with organizations like the Catatonia Foundation is where I would start.
Okay. And your clinic name is?
It's the MIND Clinic. It's Medical Exploration for Neurodevelopmental Disorders.
Well, this is wonderful. I know you said an hour. I like to be timely, so
Yeah,
thank you so much.
of
And
course.
Thank you so much.
yeah, we keep me posted if new developments happen, or if you feel like there's a talk or someone that I should consider having on. I would love to hear. You're kind of in that world more than I am, but I'm definitely passionate to educate people. So,
That sounds great. Thank you, guys.
all right.
Thank you.